Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this presentation, we're just going to review renal failure, acute and chronic. Okay, so acute kidney injury, new term, chronic kidney injury, new term, essentially covering renal failure, kidney failure. So, acute kidney injury is defined as an abrupt, within about 48 hours, reduction in kidney function. And this is based on an elevation of serum creatinine and urea, a reduction in urine output, oliguria, and a need for some form of renal replacement therapy, whether that be continuous or whether that be intermittent. Or this could be now related to hemodialysis or peritoneal dialysis. Now, renal failure or acute kidney injury has three specific stages: pre, intra, and post-renal failure. And the term acute kidney injury seems to be replacing such terms as acute renal failure and acute renal insufficiency. Now, as far as the classifications go, I already stated. We have pre-renal causes, which means before the kidney. We've got intrinsic renal causes, which is within the kidney, and post-renal causes, which is after the kidney, in the urinary tract. Now, when we look at pre-renal, what is before the kidney? Blood. So this is a result of impaired blood flow to the kidneys. And anything that decreases blood flow to the kidneys will decrease renal perfusion, glomerular filtration, and kidney function. So therefore, any of the shocks, hypovolemic shock, hemorrhagic shock, cardiogenic shock, septic shock, anaphylactic shock, anything that affects cardiac output, things like severe dehydration, severe burns, because they could be related to blood flow. Other than that, you've got the acute coronary syndromes, which can be STEMI, non-STEMI, any heart failure or disease which affects cardiac output, and certainly severe infections and liver failure. And often here now the use of non-steroidal anti-inflammatory drugs. So intrinsic is actually damage to the kidneys. Something has damaged the actual kidney itself. And this can be related to thrombosis, atherosclerosis, glomerulonephritis, any infection, any autoimmune disorder, and one could be lupus, causing glomerulonephritis and acute kidney injury and essentially chronic kidney injury. Could be medications like chemotherapy medications, certain antibiotics, dyes being used during imaging tests, scleroderma, thrombotic thrombocytopenic purpura, toxins such as alcohol, heavy metals, cocaine, and situations that now cause rhabdomyolysis. And even here, the rare one, tumoriasis syndrome. But this is now indicating that there is damage to the actual kidney itself, intrinsic, in the kidney. Then you have post-renal, and this is to do with obstruction to urine flow from the kidneys. So we're talking about urine flowing out of the kidney into the ureters, the urinary bladder, the urethra, and this can be as a result of kidney stones, urinary tract thrombosis, bladder nerve damage, enlarged prostate as a result of benign prostatic hypertrophy, or just prostatitis, bladder cancer, prostate cancer, cervical cancer, colon cancer. Anything that obstructs urine flow after the kidneys, the urinary tract. Now, what are some of the manifestations of acute kidney failure or acute kidney injury? Well, again, typically you're probably going to have oliguria. You will probably be anxious, confused, suffer from fatigue, have nausea, maybe have edema, not only peripherally, but pulmonary edema. You can have cardiac dysrhythmias as a consequence of abnormal electrolytes accumulating, such as hyperkalemia. You can have chest pain and angina because your system is being overloaded with fluid. And this can result in neurological problems, the worst one being seizures and coma in severe cases. So when we come to the complications associated with acute kidney injury, these can be because the system is overloaded and you can't get rid of excessive fluid which is accumulating in the body. And this can result in acute pulmonary edema, cerebral edema, peripheral edema, effusions everywhere, whether it be in the lung, pleural effusion, pericardial effusion. You can get pericarditis, muscle fatigue, and you can develop something called the uremia syndrome because urea is accumulating. This can cause heart failure, heart dysfunction, cerebral edema, which can result in seizures and level of consciousness changes. You can develop something called uremic encephalopathy, which basically means because you have urea accumulating, this can affect the functioning of the brain. And typically this could occur at a level where you've got your estimated glomerular filtration rate falls and remains below 15 mils per minute, normal being 60, even better 90 mils per minute. And this can result in permanent kidney damage, end-stage renal disease and death. Now, when we come to assessment, history and physical assessment is always important. But again, we're looking at serum urea and creatinine, complete blood count, which can identify things related to hemoglobin, anemia, even blood counts that affect now clotting factors. Urinalysis certainly is an important baseline that all nurses should be aware of because you can have your dipstick and that can indicate things like hematuria, proteinuria, leukocytes in the urine, albuminuria. Also, there are imaging studies. So renal ultrasound, renal CT, renal MRI. And these can identify, especially post-renal failure, things like tumours, benign prostatic hypertrophy, hydronephrosis, obstructions. And as a last resort, as we've mentioned previously, a biopsy can be done, and a renal biopsy can be done to determine possibly pre-renal causes and post-renal causes and intrinsic causes. When it comes to the management, well, if you have acute kidney failure, you have to be in hospital. So, because again, this makes sure that the healthcare providers are assessing you effectively, or the person with the acute kidney injury, for renal perfusion and maintaining hemodynamic stability. And most importantly, avoiding hypovolemia. And a mean arterial blood pressure of greater than 65 should be optimised with certain medications such as positive inotropes like dopamine, dobutamine, and certain medications that decrease afterload and reduce preload like glycerol trinitrate, or veno and vasodilators as a general term. It's important to pay attention to electrolyte imbalances like hyperkalemia, hypophosphatemia, hypomagnesemia, hyponatremia, hypernatremia, and whether the patient has now got a metabolic acidosis. These are all important derangements which need to be rectified. Now, diuretics as a general rule are used, but the evidence shows that they don't really improve morbidity or mortality or renal outcomes, and shouldn't be typically used to prevent or treat acute kidney injury unless related to volume overload. Other factors that could be involved in management could be renal replacement therapy, which again basically is intermittent or in the intensive care, it could be continuous. And this can be hemodialysis, or it could be peritoneal dialysis. What's the prognosis of acute kidney failure, acute kidney injury? Well, people with acute kidney injury are more likely to go on and develop chronic kidney injury in the future. And they're also at higher risk of end-stage renal disease and therefore a premature death. So therefore, monitoring a person with acute kidney injury is vital because you don't want them to go on and develop chronic kidney disease. When we look at chronic kidney failure or chronic kidney disease or chronic kidney injury, this involves the gradual loss of kidney function. And in the early stages, stage 1 to 3 of chronic kidney disease, there are very few clinical manifestations, and the person may not even realise that they have chronic kidney disease until the condition becomes more advanced. The treatment for chronic kidney disease focuses on slowing the progression of kidney damage by controlling conditions such as diabetes mellitus, hypertension, making sure the person is compliant with medications prescribed by their physicians. Controlling the cause doesn't prevent the kidney damage from progressing, because chronic kidney disease may or will progress to end-stage kidney failure in some cases, which is fatal, and without dialysis, hemodialysis or peritoneal dialysis, continuous or intermittent, it's essentially a death sentence. So the treatment for end-stage kidney failure essentially is dialysis or a renal transplant. Generally, there are 5 stages to chronic kidney disease, going from mild to end stage. Mild, stage 1, essentially means that the glomerular filtration rate is 60 to 120 mils per minute. As recommended by the National Kidney Foundation, the normal glomerular filtration rate is typically 90 to 120 mils per minute per body surface area. As the disease progresses, the glomerular filtration rate declines. And once it gets to about 30 to about 40 and lower, the person typically requires some form of dialysis. But certainly less than 15 mils per minute per body surface area is definitely an indicator for end-stage kidney disease and hemodialysis or a kidney transplant. What's the etiology of chronic kidney disease? Not dissimilar to acute, but diabetes mellitus, hypertension, infections that result in inflammation, polycystic kidney diseases, an enlarged prostate, kidney stones, cancer, vesiculourethral reflux, and pyelonephritis. What are the clinical manifestations? Possibly similar again to acute kidney injury, acute kidney disease, nausea, vomiting, anorexia, fatigue, weakness, polyuria, oliguria, and uria. In impaired mentation as well, peripheral edema, pulmonary edema, generalised edema. In addition to now probably uncontrolled hypertension, often referred to as renal hypertension. What are some of the complications of chronic kidney disease? Heart failure, hyperkalemia, anemia. Remembering that the kidney has got numerous functions, one being the synthesis of erythropoietin, which it no longer does with chronic kidney disease, which results in anemia. Osteoporosis, again, one of the functions of the kidney is to reabsorb calcium. Things to do with reproduction can be affected. And again, things to do with now the brain, cerebral edema, which can result in seizures as a result of uremia. And the ultimate complication being end-stage kidney disease. Assessment is basically the same as for acute kidney injury. Management is essentially to treat the complications or clinical manifestations, which means stay on your antihypertensive medications. Take the ordered diuretics, even though they may not be of any great benefit. If prescribed by the renal physician, the patient should be compliant. Iron supplements, because again, they're going to be anemic. And again, often here, blood transfusions. Supplemental erythropoietin. Anti-cholesterol medications if related to cardiovascular disease. Calcium supplements if hypocalcemic. And certainly low sodium, low protein, and fluid restriction. A low protein diet reduces the nitrogen load, and if that's reduced, urea will be reduced. Ultimately, end-stage kidney disease and management will be primarily hemodialysis, peritoneal dialysis, and kidney transplant. Let's review. State the 3 types of acute kidney injury and give one example of each. So what we have is pre-renal, intrinsic, and post-renal. Pre-renal is anything that decreases blood flow, blood pressure, so any of the shock syndromes. Intrinsic is to do with damage to the kidney. So this could be as a result of infections, inflammation, glomerulonephritis, or any of the bacterial or viral infections. Post-renal obstructs urine blood flow, so things like kidney stones, urethral stricture, tumours, benign prostatic hypertrophy. Okay, that's it for this session. Thank you. If you found this to be of any benefit, please recommend it to your friends and colleagues, and subscribe only if you feel that they're beneficial. Thank you, and God bless you all.